Hello, everybody. Welcome to this session today where we're looking at knowledge user engagement and designing for implementation. So my name is Molly Byrne. I'm Professor of Health Psychology at the University of Galway in Ireland, and I'll show you where I'm based in a second. First of all, I want to include the land acknowledgement. I have no disclosures, and I want to acknowledge all the partners and funding partners for the CBITN. So the objectives of our session today are, hopefully by the end of this session, you will have a better sense of how to engage relevant stakeholders, including patients, public, healthcare professionals, and knowledge users. So any of those end users of research throughout the entire research process, with the aim of maximizing intervention relevance, fidelity, effectiveness, and implementation. Hopefully you will have a better sense of how to develop a public and patient involvement strategy. And we will also be discussing the use of frameworks and theories from behavioral science to systematically develop and evaluate implementation interventions. So before we get started, I'm based in University of Galway in the west of Ireland. You can see us here on the map. We're on the west coast, the Atlantic coast, looking over to Nova Scotia. And you can see the photos below of our campus and Galway site on the west coast of Ireland. Within the Health Behaviour Change Research Group, then, our aim is to improve population health by developing and promoting an evidence-based approach to health behaviour change interventions. And more specifically, we aim to lead the behavioural research agenda by identifying priority issues which impact on health. Our bread and butter is really developing, piloting, and evaluating complex interventions. And we do this by using evidence-based behavioural theory and employing theory-linked behaviour change techniques. We want to advance the science and the methods, and this is where we link in with IBTN. We want to build capacity by establishing a critical mass of researchers and delivering training. And ultimately, we're doing this to impact on health outcomes by engaging the public and all end users of our research. So that's very much the focus for the session today. So a number of years ago, back in 2017, I had the pleasure of spending a little bit of time with Simon Bacon and Kim Lavoie in Montreal to conduct a research prioritization research study. So the aim of this was to conduct an international Delphi consensus study to identify and achieve consensus on what were the priority methodological issues for behavioural trials among members of the International Behavioural Trials Network. So we've published this work if you want to follow up on it, but I'm raising it today because of the priority topics that were identified, which were intervention development, so improving our methods about specifying intervention components, tailoring our interventions to specific contexts and populations. Then another priority area was intervention implementation. So this was around how best to disseminate the findings of our behavioural trial research and measures and methods for making sure that our interventions are implementable into practice and policy. And then finally, another priority area was development of novel research designs to test behavioural interventions. These would be things like smart trial designs or studies conducted within the MOST framework. But for today's session, I'm going to focus very specifically on this central one, which is intervention implementation. So why do we need to think about implementation? Well, I think you're probably all familiar with the identified gap between what the research evidence says and what happens in routine healthcare. Sorry, I'm just moving my little down there. So an implementation gap has very much been identified. So for example, only 30 to 40% of people do not receive care according to current scientific evidence. 14 to 25% of healthcare provided is not needed. And 85% of research is wasted. So these are quite depressing figures really for a health researcher. And I think it is all of our responsibility to ensure that the work that we do is of better quality and has more chances of developing evidence that's going to be implemented into practice and change what's actually done in practice and policy. And this is what's classically called the implementation gap. So I'm going to talk about two things today. The first is knowledge user engagement as a strategy that as health researchers we can use to try and reduce this implementation gap. And you may want to follow up on this reading here, in which I have argued for the case of stakeholder engagement as an important component of increasing the impact of our behaviour change intervention research. So knowledge user or stakeholder engagement, there are a number of different terms that can be used here. You may be familiar with some of them more than others. Stakeholder engagement is really any active involvement of people who use the research. So this might be public, patients, health professionals, other decision makers, for example, people in the Department of Health. A user-centered approach then is a particular perspective in research, making it more likely that interventions are going to be taken up and used. And I've included here the photo of one of my favorite research studies, which is the Football Fans and Training. And this was a program designed originally, the original study was conducted in Scotland, where they had identified and a particular need among middle-aged men who were overweight or obese. And basically these had proved through a number of previous interventions to be a particularly hard to reach group. So by adopting a user-centered approach where the researchers really worked with a number of community groups with these end users, so these middle-aged men, they developed this intervention, which was very much in line with something that was really going to motivate this group. So this was a weight loss program that was embedded within the local football team, and it was highly successful in terms of leading to weight loss. The final term here is integrated knowledge translation, and I think that this term originally comes from Canada, and really it's a method to increase the relevance and applicability of research, and again focusing on engaging knowledge users throughout the entire research process, with a real emphasis on engaging the end users right from the start of the research process. So these are a few different terms that you may be familiar with that are of relevance to the session today. So I'm going to first of all give one example of a research study that I have been involved in for the last number of years now, called the D1Now study. And our aim in this research is to improve outcomes among young adults with type 1 diabetes. So we all know that young adulthood is a challenging time, full stop. There's a lot of changes going on. People are maybe finishing school, moving into employment, potentially leaving home. It's a potentially quite disruptive time of life, combined with all the changes that are going on at a biological and hormonal level. And diabetes self-management is a very demanding task. So it's a chronic disease where people with diabetes need to be checking their blood glucose, managing the levels. They need to be managing what they eat, being very careful about the carbohydrates and counting their carbohydrates, exercising and regularly attending medical appointments. So it's a chronic condition that for anyone to be able to manage it is very demanding, but particularly at a time of life such as young adulthood, where there are a lot of other upsets happening, it can be a particularly challenging time. And we do know this, that from the evidence, that young adults are a particularly high risk group. So they are at high risk of not managing their condition, not attending, and having poorer clinical outcomes, including blood glucose levels, which can be actually very serious and can even result in death if not managed properly. We also know that among this group in particular, there are high levels of diabetes distress. Now, what we don't know is what types of interventions really work to improve young adults' engagement and self-management of their condition. So this is where we started with the D1 Now study. And I think there are two key strengths to this program of research. The first is that we have had a patient and public involvement approach embedded from the outset. And I'll tell you a little bit more about that in the next slide. The second is that we've systematically developed our intervention using behavioural science theory. So what I hope to show you in this presentation is how we've really systematically and scientifically developed the intervention, but very much also including a patient and public involvement arm. So the patient and public involvement was embedded, as I said, from the outset of this research. So here on the left of the slide, you can see the flyer that we had posted at the start of the study when we wanted to recruit our young adult panel. I think of note, we were supported in developing our methods for the young adult panel by a community mental health organisation called Jigsaw. This organisation very much took these participatory approaches on board from the outset. And I always like to think of a good example of how they operated was that they would never recruit a new member of staff to Jigsaw unless there was a member of the young adult panel as on the interview board. So a genuinely participatory and collaborative approach to engaging with the young adults. And within D1 Now, the young adults were involved in all aspects of research, from developing the intervention, applying for funding, presenting the research findings, and worked very much as part of the research team. You can take a look on, we have a nice website for the study, and you can take a look at this little video clip on YouTube in your own time if you're interested to hear a little bit more of the perspective of the young adults themselves who were involved in the panel. So we systematically developed our intervention, first of all, reviewing the evidence base and identifying and developing theory. So we did this using the behaviour change wheel, in which we first of all sought to understand what capability, opportunity and motivation factors were relevant to our population of interest, so to young adults with type 1 diabetes. And we then modelled these with engagement from our young adult panel to develop our D1 Now intervention. And part of this was a collaborative meeting that we organised as part of that development pipeline. And this was called our Strength in Numbers event. So you can see here some photos from the event. It was a large event. We had public attendance at the event, but very much our young adult panel was very much in the lead of organising that event and worked very closely with, as members, active members of the research team to develop the intervention. So the areas that we focused on for discussion were threefold. So the way young adults were introduced to the adult diabetes clinic, their attendance at the diabetes clinic and how appointments were made, and then the importance of building relationships between young adults and the service providers. So we developed an intervention with three components. The first of these was a support worker. So this would be a person who would work very closely with the services to be a kind of a connection between the young adult and the health services. An agenda setting tool, which was an interactive tool in which the young adult would complete before the consultation what their priority issues were, to allow that then to set the tone for the consultation with the healthcare professional. And finally, an online app, a digital messaging service that would check in with young adults about their appointments and about whether they had managed their, done their various management activities. Another thing that we engaged our young adult panel in was identifying what outcomes were going to be important in our research. You may be familiar with the idea of a core outcome set. So a core outcome set is a minimum group of outcomes that are recommended to be measured as part of a clinical trial in a particular clinical area. So here what we have done is we developed our core outcome set for young adults with type 1 diabetes, in which we have 4 kind of classic, if you like, biomedical outcomes, the HbA1c being the primary one among these, but numbers of DKAs, number of severe hypoglycemia events, and clinic engagement. And then on the self-report side, we have diabetes distress, quality of life, self-management, and perceived level of control of diabetes. So a key part of the core outcome set methodology is the inclusion of people with the condition, people working as healthcare professionals within the services. So again, this was another very important role for our young adult panel. And I think of interest, when we did engage our young adult panel in this work, what we found was the young adults themselves were much more interested in the patient-reported outcome measures. So things like diabetes distress and quality of life were much more important to them than some of the more classically measured medical outcomes, such as the HbA1c. So again, this is an important way to make sure that the research is relevant to the end user, so that our trials of interventions are really actually addressing outcomes that people with the condition actually care about. So we have now published from our D1 now, we've published the findings of our randomized controlled trial. What we found is that 2 of our 3 intervention components were feasible and acceptable. The Florence SMS app, so the digital messaging service, was not acceptable. Our people with diabetes didn't like it. They found it annoying. They found after a few weeks they ended up turning it off. So what we have done in launching now our D1 Now cluster randomized controlled trial, which has just started in February of 2024, is that we have a 2-component intervention with the support worker and the decision, agenda setting tool. Apologies. So we're just about to kick off that cluster randomized controlled trial now. So reflecting on this example, I think the take-home messages for you, maybe as people who may be thinking about your own research, is who are your stakeholders? It's important to consider all end users. So is this people with a particular clinical condition? Is this policymakers? Is this going to be healthcare professionals? Do you know of any organizations or other groups who could support and advise you on setting up your stakeholder engagement methods? We were very fortunate to be supported by Jigsaw, the mental health community mental health organization. But you may, if you feel that you will need to get help to set up, say, your patient and public involvement panel, it might be good to reach out and see what resources are out there. And then in terms of thinking about how well engaging with a patient and public involvement panel can work, some things to consider are it's very important to engage them early. So had we really done all the development work of the intervention and then brought the young adult panel on, and they would then have been telling us things like, well, we don't like this bit, or I don't think that bit's going to work. But then really it's actually would have been too late to actually make any changes. So it's very important to engage them early. I think another aspect of engaging them early is that it actually gives them ownership of the work. So our young adults have gained a huge amount, I think, from their involvement in the research, and are very committed to ensure that the work continues and is implemented in any way, depending on whether we find our intervention is effective. It's important to think about what roles your stakeholders might have. So are they going to feed into reviewing your papers? Are they going to advise you in relation to outcomes? Because I know from, when we have been holding stakeholder meetings with our young adult panel, people didn't mind coming together and giving it time, but they did want to have a nice specific task to actually take responsibility for. They didn't just want to kind of come along and chat. They really wanted to have a very specific role. Also, I would say that resourcing and actually running patient and public involvement can be both labour and cost intensive. So it's very important at the outset when you're applying for research funding that you're budgeting for proper patient and public involvement work. And you need to ensure that you have the capacity within your team to, for example, run evening meetings with your panel. It's also important to know that everyone on the team is on board with this approach. So I think it's very difficult if there's only one or two people who are keen to get good stakeholder engagement or a patient and public involvement strategy if everybody on the team does not support it. And I think we were very fortunate in D1 Now, where Sean Deneen, who is the principal clinical lead on the work, was very much in favour and is very much driven the patient and public involvement approach. So I'm going to move on now to the second part of the presentation today, which is looking at designing for implementation. So the two sections are very much linked. You may be familiar with implementation science, and really this is the study of any of the methods which promote this implementation of research into routine practices or policy. And again, another paper you might want to have a look at. These are all on the recommended reading list, which was led by Justin Presseau in Ottawa. And I worked also as one of the authors on this paper. And really what we're discussing in this paper is the importance of implementation benefiting from the methods within health psychology and the potential overlap and synergy between those two disciplines. So I'm going to tell you about my second of my two examples in the presentation today of a second study, and this was very much an implementation intervention, and I'm just kind of taking you going back a step before we had started the study to where the study came out of, because I think this is actually an important message for the broader work. So this study that I'm going to look at, the Making MEC Work study, was born from a number of workshops that we ran, actually facilitated by Professor Maureen Dobbins, who is based in Toronto. Maureen is a knowledge broker, and she worked with us in the Health Behaviour Change Research Group and our policy partner group, who are the health and wellbeing team in Ireland, so the National Health and Wellbeing Policy Body. And she worked with our two groups to try and see what synergies could be achieved to strengthen research partners and to develop a research agenda. So as researchers, we wanted to know, okay, well, what are the important questions in the health and wellbeing space? And within the health and wellbeing space, they wanted to know, okay, well, what are the skills in terms of within this research group that could support us in terms of answering some of the questions we have. So from these workshops, we developed a research agenda, and specifically, we developed a research proposal for our Making MEC Work project. So this was a project to optimise the implementation of the national Making Every Contact Count programme in Ireland. So we know that healthy behaviours are critical to promoting health and reducing chronic disease. So we all know that the prevalence of poor diets, lack of physical activity, smoking, and other behaviours are critically important in terms of reducing levels of chronic disease and improving health and well-being. We also know from the international evidence that brief behavioural interventions delivered during healthcare consultations can support behaviour change and improve health outcomes. And indeed, there are international guidelines that recommend that all healthcare professionals should be trained and enabled to deliver brief behavioural interventions. So these are interventions where healthcare professionals discuss some of these behavioural risk factors and try and support their patients to make the behaviour changes that would be healthful. So in Ireland, we have a national programme called the Making Every Contact Count programme that was introduced in 2018. And this programme aims to train and facilitate all health and social care professionals to develop the competencies needed to deliver these brief behaviour change interventions and to then deliver them within their healthcare settings. So when we had our brainstorming workshops with our health and wellbeing partners, they raised that this was an important issue for them. So there was a national programme that we knew from the evidence was effective. So the brief behaviour change interventions are effective in terms of changing health-related behaviour, but we knew that they were only effective if they were actually implemented in practice. So the healthcare professionals need to attend the training. They need to then deliver the brief behaviour change interventions. And we knew from the Irish setting that implementation was proving challenging. So evidence was lacking around the enablers and barriers of the implementation of this national programme. So the aim of our Making MEC Work project was to develop evidence-based strategies to optimise and scale up the implementation of this programme nationally. So I won't go into too much detail on this particular study, but we had 3 parts of the study of developing our collaborative implementation strategy. The first and second were an online survey and a qualitative interview study, and the aim of both of these was to better understand the barriers and enablers to MEC intervention delivery in Ireland. And then in our third study, we pulled together the findings of both study 1 and study 2 into a final consensus study, the aim of which was to agree the strategies and recommendations to enhance implementation. So for this work, we used 2 theoretical frameworks which can be used in combination. The first of these was the behaviour change wheel, which at its centre has capability, opportunity and motivation. So we wanted to understand what were the predictors of whether healthcare professionals actually delivered these brief behaviour change interventions in practice. And then we followed through from the behaviour change wheel to the theoretical domains framework to try and ensure that the implementation strategies that our work suggested or recommended were based on this theoretical framework. So you can see there that the theoretical domain framework domains in the yellow there are things like environmental predictors or physical predictors or social predictors. So again, you can read up separately on these frameworks, but I think the core message here is that for implementation, intervention, research, it's important that we have systematic and theory-based approaches to understanding the behaviour that we're looking to target. So here, healthcare professional behaviour change, and then use this understanding to systematically develop our intervention recommendations or components. So this screen really just gives you a snapshot of the policy document which we developed from the Making MEC Work research study, in which we highlighted 9 specific recommendations to enhance the programme. And on this slide, you can see how we've organised these recommendations into either systems level. So these are recommendations that really need to go to the highest level of the health services and how it's organised. So for example, number 1 is to provide dedicated time to practitioners to attend the training and to use the Making Every Contact Count programme. So this is something that needs to be organised at the very highest levels of the health service. And then the recommendations highlighted in blue there are more at an organisational level of the Making Every Contact Count implementation team. So these are things that group who worked closely with us on this research can take on. So for example, developing service directories for healthcare professionals to refer service users. So these are things that can be done by that local team. And it was very helpful that we managed to organize these different recommendations into the different kind of end target knowledge users, if you like, to ensure that they would be actionable. So within this research, we had a wide range of dissemination and knowledge translation opportunities. So I suppose this was one of the key findings from this type of very engaged approach to research, that because the health and well-being division had identified this as an important research need, they were very keen to work with us to facilitate the research and to facilitate the dissemination of the findings. So as a research team, we had meetings with all sorts of groups within the health services, including an important meeting with the HSE executive management team, who would be the key decision makers within the health services. So I think that's an important aspect of this type of stakeholder engaged implementation research. So some reflections then, well, it was possible. This was certainly a different type of a research study that I had been involved in before. It addressed something that had been raised to us that was important, that was a hot topic. I think often as researchers, we spend a lot of time doing research that's not necessarily, not many people are actually interested in the answer to the research. So I suppose what I really liked about this study was there was a lot of interest in it and people really wanted to follow up on it. Within this type of research, relationships and partnerships were critical. So a key thing in this Making MEC Work project was that there were two principal investigators, myself as the academic principal investigator, and then the other principal investigator was a knowledge user, and this was Marie O'Brien, who was the director at that time of the Making Every Contact Count programme. And this was how our Health Research Board had set up the research award. And this made a really big difference because it was kind of shared responsibility of the project. And this ownership and sharing this ownership, I think, is very important. There was also another aspect of this award in that health and well-being had to co-fund the research amount for, I think it was maybe 20%. So they had actually invested money in the research. So they really wanted to get value for money and they wanted to be able to use the output from the research. In this study, there was a direct route for implementation, and that was very satisfying. And I am aware that the Making Every Contact Count team are currently using our recommendations to develop the implementation of the programme. And hopefully this will improve the impact. On the more challenging side, or the negative side, certainly this type of engaged research can be challenging because I suppose as researchers, we often speak to people who are like us, whereas when you broaden out the membership, if you like, of the research team, you get some very different perspectives. And these have to be managed, and I think that ultimately they can really enrich the research, but there certainly can be difficulties in managing all of that difference. There can be different organizational cultures. So for example, universities and health services have very different cultural organizational rules and different organizational cultures, and that can be problematic. I think the key thing there is that you have regular communication and you give each other an opportunity to understand each other's organizational culture. I think this type of research very much pushes researchers outside of their comfort zone. And certainly there were a number of times where I felt as a researcher that we were kind of put on the spot a bit to present to people who, we wouldn't have been used to presenting in those settings. So I think we need to accept that if we want our research to be implemented, we will have to be pushed outside of our comfort zone. Sometimes, if not everybody is on board, that can be challenging as well. And I think that's probably the way with all research. And then the practicalities can be difficult as well. There may be constraints within the grant funding, and when you're working in close collaboration with health services, you are really at their mercy. So we conducted this work during the COVID-19 pandemic, and I think, like most things, we were very much derailed for a time, and there were challenges accepting that. So my final lessons and reflections then on this whole piece of work, looking at the importance of engaging end users of the research and key stakeholders to enhance implementation, are that relationships and communication are key. So it's really critical that if you're working in a particular space, that you spend time and make effort to establish the relationships that are going to be needed to conduct the research capably and to ensure that findings from the research are going to be implemented. I think partnership from the outset is ideal, and this can be challenging because very often as researchers, we're slave to the next research funding call. So I think within larger research groups or research institutes, formalizing collaborations, for example, with health services partners can be very useful, because it does allow opportunities then, things like when we had the collaborative workshop, which was facilitated by Maureen Dobbins to identify our research agenda. That was only possible because we had these partnerships which were being facilitated by a bigger group. I think co-creation and stakeholder engagement within projects does increase success, ownership, and the potential for impact and implementation. However, it has to be said that the evidence for that statement is still slightly grey, in that we do not have top quality evidence, I think, to really make that statement clearly. So again, I think there's potential for future research to focus on seeing what the evidence is there for our different methods. I think the lines between research, policy, and practice can be fuzzy, and I think that that's fine for people involved in applied research. I think that's just part of the deal. I think as researchers, we need to be willing to go an extra mile and to be willing to move out of our comfort zones. And I think we need to also accept that we can't do it all and seek supports and expertise elsewhere when possible. So I want to acknowledge my funders, the Health Research Board and the Ireland Canada University Foundation. I want to acknowledge my collaborators on a number of these projects, and in particular Kim Lavoie and Simon Bacon from the IBTN. And I would be happy to be contacted following this if you have any queries or questions. Thanks very much.